Perfect, we're now live. Hello, web shadowers. Welcome to the second session for summer week 2. Just as a reminder, we will be hosting 1 to 2 sessions a week on Tuesdays and Thursdays in the evening for our summer semester of web shadowers. We're very excited and want to thank you all for attending our session this evening. With that being said, today we have the pleasure of hosting Dr. Reilly, who will be teaching us all about emergency medicine again. As always, please remember that the Google form will be posted in the chat box and in the description of this video at the end. With all of that being said, Dr. Reilly, you may begin whenever you're ready.
All righty. Hi, everybody. Don't know where you are, probably all over the country or wherever you are, morning, night. I'm on the East Coast down in Tampa Bay right now. Beautiful weather. Tampa Bay Lightning in the playoffs right now. It's fantastic. So anyway, without further ado, I'm going to talk to you guys a little bit about emergency medicine. And I got a couple cases. If we have time, we can do the second one. The first one, we kind of went through the first time I was here, but I'm going to focus a little bit more on one aspect of that presentation, which was a presentation on trauma. So let's get started. So I am Dr. Chris Reilly. I am actually at the end of my first year of residency, which is kind of crazy. This year has kind of flown. So who am I? A little bit about me. So again, I'm a first year resident at Brandon Regional Hospital, which is right outside of Tampa. It is a large community hospital, very busy, over 125,000 ER visits a year. I actually just had a shift late last night, had conference this morning, which every week you have conference once a week, about 5 or 6 hours of lecture in the morning. And then you either go to shift or you go home if you're off that day. And I'll get to that a little bit later about emergency medicine, some of the perks. So I did my undergraduate at the Johns Hopkins University down in Baltimore, Maryland, where I played baseball, as well as majored in biology and minor in entrepreneurship and management. Loved Baltimore, great city. I did a post-bac at Drexel University in Philadelphia, where I got my Master's of Science in Biomedical Sciences. That was my first gap year. And then I took a second gap year to scribe in the ER in Trenton, New Jersey. And this scribing job actually got me super interested in emergency medicine. It really opened my eyes and got me to connect with some of the nicest people in the world, best docs, awesome personalities, and just the spectrum of pathology that you see in emergency medicine is fantastic. It's never a dull moment in the ER. You can get anything from a broken arm to somebody coming in with a heart attack or stroke or trauma that we'll talk about. So medical school, I went to St. George's University in West Indies, Grenada. So I am a United States international medical graduate who matched into a United States residency program. If you are thinking about doing a Caribbean school or USIMG, if you have been denied a couple times, or you just want to just send it and try to do the best you can, take the leap. I did it. There's a lot of us that have done it. We have a very good match rate from St. George's. There's a lot of other Caribbean schools too. If you guys would like more advice on that, you can follow me on Instagram at Doc Riles. You can ask me questions about it. I have a lot of friends too who also give plenty of advice about that. So I know it's a hot topic. So anyways, some hobbies of mine: music. Love making music. I actually was recording some stuff today. I play guitar, I sing, I produce my own stuff, and try to collaborate with different people, different artists as much as I can. And then working out, golf, basketball, baseball. And my buddy, Dr. Schuper, and I, Dr. Schuper just actually gave a lecture yesterday, I believe, or 2 days ago to you guys. He's a neurosurgical resident. We record this podcast. It's called RESLIFE, the advice on the journey to medicine. And it's on all streaming platforms now. We use Anchor, which is a great platform. And it's primarily Spotify, but we are on Apple Podcasts, Google Podcasts, all these other podcast platforms. So that's a little bit about me. And here's a little quote from an article I pulled. about emergency medicine. What we all have is the inner drive to go toward danger, not away from it, to treat each and every person, regardless of race, gender, or anything else, as a person who we can help. When we do, they may turn around at the end of the day and say, "What was that doctor's name again?" But that doesn't matter. They know we were emergency physicians. They know that we were the best thing that they saw on their worst day. And that's what makes EM special. And this could not be more true, guys. After I've finished up my intern year, my first year of residency, this is by far so true. Like every person you go in, you introduce yourself several times, and they forget your name. They don't know your name, but they thank you up and down. They're so pleased with everything, and sometimes they're not. But you have to take the good with the bad. You're gonna have good days and bad days. So anyway, this could be what my day looks like, right? You walk into the room, patient looks fine. There's really not much going on, pretty stable patient. And then, hold on. Sorry, guys. Let me put on that do not disturb. All right. All right. So anyway, you guys could, this could be what my patients look like, right? Completely normal, in no acute distress, just coming in because they're worried about something. And a lot of these patients will just we'll run some tests, they'll be fine, or maybe they'll have a minor problem and we'll tell them to follow up with their primary care doctor. And that's fine. And then some days it'll be like this. Absolute chaos. But the best thing you can do in emergency medicine is stay calm in chaos, because calm breeds calm. If you reflect a calm atmosphere around yourself, everyone else in the room will also follow. If you are running a code, if a patient comes in cardiac arrest, CPR is in progress, you're at the head of the bed, you're ready to intubate, you are calm, everybody else in the room is calm. And every resus that you stay calm in as the leader goes very well. And that's just the truth. EM, you have to read EKGs all day long. It's actually really cool that you could read these things, because when I first was a scribe in the emergency department, I had no idea what I was looking at. It's like, what are all these squiggly lines? I have no idea. What are all these letters they're saying? PQRST, what's this wave? What's that wave? EKGs are extremely complex, but in the emergency department, you see them so often, you start to recognize when things are not so good. Like in this one, you have something called alternans, electrical alternans, which can be a sign of cardiac tamponade, which is fluid around the heart leading to all sorts of badness in the body. But again, these are little things that you pick up over time. This is a normal EKG. And you guys will see this. If you go into medicine, you'll read plenty of EKGs. So that's another thing. The procedures. There are so many procedures in emergency medicine. It's a crossover between critical care medicine and surgery and internal medicine and family medicine and psychiatry. It's literally all of the specialties in one. So if you have to intubate someone, we got the endotracheal tube right here. We got the MAC blade right here, and you got to put it in their trachea. So you have that. You can do spinal taps if you're suspecting someone to have meningitis. You can do needle decompressions. You can do thoracentesis, which is draining of fluid from the lungs. You can do a thoracotomy or a chest tube placement, right? Chest tube placement, which we'll talk about today. And pericardiocentesis, which is actually very intense. Again, tamponade, like I was talking about before, is fluid around the heart. And you can actually go in there via ultrasound or interventional radiology and drain it. Central lines, all sorts of stuff. This is the algorithm for ACLS, which is basically advanced life support, advanced cardiac life support. All right. So what's so special? You see patients every day that you don't know what's going on. You don't know their past medical history. You know nothing about them. They say, "Doc, this is bothering me." And then you have to just act like Sherlock Holmes and try to figure out exactly what's going on with these people. I find that really cool, actually. You feel literally like a detective. You have to see if these people are sick versus not sick. As I said before, the first patient, you can see them and be like, oh, this guy's fine. Like, we'll send them, outpatient. You have to figure out their disposition. Or someone comes in cardiac arrest, you get return of spontaneous circulation, and you send them to the ICU. These are different things that you have to figure out. Quick rapport with your patients. Again, you don't know these people. They are uncomfortable, and you have to find little things that can make them feel more comfortable. Whether it's somebody wearing a New York Giants hat for me. If I see a Giants hat, oh, you're a Giants fan, you from New York? Oh, I'm from New Jersey. I love the Giants. Just like little commonalities to make the patient feel a little bit more comfortable. Just be human. Critical decision making. This is huge, especially in a code. You have to think very quickly on your feet. You have to think of all these differentials. And when it's time to do a procedure or time to order a medication, a life-saving medication, you have to know the dosage down pat. You have to be able to do the milligrams per kilogram to actual dosing, stoichiometry. That actually does come in handy, guys. So that's important. Multitasking. My God, you're balancing like sometimes 10 active patients at once. Mr. Smith in room over here is his blood pressure's low, while Mrs. Johnson in the other rooms having a psychotic episode. We need to sedate her. While somebody else is doing something, and you're just one person, and you have all these nurses and techs talking to you constantly, trying to ask you to order things, and it could be a little bit overwhelming, but that's part of the challenge. Teamwork, as I just mentioned, nurses, techs, EMS, you're working with so many different people, and emergency medicine is such a team sport. You have advanced practitioners, APPs, you have the PAs, the NPs, they're working, alongside you and trying to help you carry these patient loads. So it's definitely a team sport. Procedures, as I said before, there's so many procedures. They're so much fun, and you get to actually see you do good work for these people and see that instant gratification. And you are a safety net for society. You're a safety net for people that don't have primary care doctors. You're a safety net for people that may not be on the same socioeconomic level as you, or maybe homeless. Again, I saw a homeless guy the other day. He had a dry gangrene of his left foot. His toe was completely just rotted down to the bone. And that poor man came in, had no idea what was going on, and that I was his safety net. And he's now in the on the floors. So it's ever changing. Your work-life balance is great. Again, it's a Thursday. I didn't have a shift today, but the other thing you got to keep in mind is that you work random holidays, you work random days, random nights. They try to keep everything together, like if you're working a string of nights. Challenges, you will see things you can't unsee or unexperience. Earlier this year, I saw a 2-month-old we coded pass away. We did CPR, we did lines, everything, and it just didn't work out. And that was a really, really hard patient for me to see. That was my first pediatric code and death in the emergency department. And these are things, again, that will stick with you. But I try to look at them as a positive in terms of how I would handle it the next time, or how to handle these parents when they are, distraught because they lost their baby. Quality metrics and patient satisfaction. This is where emergency medicine is going. Even in residency, we're worried about metrics. How quickly did you see the patient? How quickly did you order labs? How quickly did the patient get dispoed out of the emergency department? Patient satisfaction. Honestly, we try to be so nice to these patients, and we really try our hardest to do what we can for them. And a lot of them are very, angry about waiting, and no one's happy in the emergency department. So I think a lot of our reimbursement is going to come down to patient satisfaction scores as well, which stinks, but it is where emergency medicine is going. Circadian rhythm, as I said before, you could be on days for 2 days, and then go right to nights for 3 days. And then your brain's like, what's going on? And this is something that you can get used to: blackout curtains, melatonin. There's a lot of different things for sleep hygiene that I've actually talked about on my Instagram page. And burnout's the biggest one, right? Burnout's something that we all hear about, and that's why a lot of EM docs actually go on to something else after they're in, the middle-aged kind of range, like maybe late 40s, early 50s. A lot of docs start looking out to urgent cares or some of these other places because you burn out pretty quickly because you're seeing so many patients, you're doing so many shifts, you're seeing people die, you're helping some people, and then some people are ungrateful, and it's like, there's really a lot that goes with that burnout. And that's a huge topic in itself that, we can talk about at a different time. And post residency. So residency in general is 3 to 4 years in emergency medicine. And what residency is, it's after you graduate medical school, you do postgraduate training for a salary that's well below what a regular doctor makes based on Medicare and Medicaid. And with that salary, you live and you work wherever that you match for residency. Residency is postgraduate training. So if I want to be an emergency medicine doc, I have to match into emergency medicine program, residency program, and then graduate from that. And then take my board exams, which is honestly, that's another thing. You just take exams for forever if you want to be a doctor. I'm almost 30 and I'm still taking exams constantly. So, you match into your program and then you do the training and then you get board certified, depending on what you want to do. Internal medicine, anesthesiology, emergency medicine, obstetrics and gynecology. There's so many, obviously. And these help you get into residency and help you prepare for the workforce. Post residency in emergency medicine, there are so many fellowships that you can do. Look at all these fellowships. Some really, really cool stuff, especially in the spectrum of emergency medicine. Forensic emergency medicine. You could do aerospace medicine. That's super cool. Disaster. Medical education's really cool. Let's see what else. Toxicology. Undersea and hyperbaric or wilderness medicine. Really, really cool stuff, guys. So emergency medicine is a vast field with a lot of different subspecialties that you can subspecialize in, but you can always be the emergency medicine doc and you don't need to do a fellowship. Remember, no path is right. You guys are all young. A lot of high schoolers here, a lot of pre-meds, a lot of people in post-bacs or gap years right now. Remember that your individual path is what makes you unique. It makes you you. My path was anything but typical. I took 2 gap years and then I went to the Caribbean, full send to the Caribbean. Crazy. Even now I think back, I'm like, wow, that's nuts that I invested everything in myself and my work ethic. And I made sure to tell myself, you can do this. You need to put the work in. And they gave me the opportunity to get my MD and apply for residency. And I made it happen. So, if you guys really want to make this happen, you can do it. Your path is your path. Don't look at the person next to you. They're doing one thing, you're doing another. You're going to fail a bunch of times on the road to getting into medical school or residency or whatnot. Again, I failed twice at getting into U.S. medical school. I didn't know about DO schools, but that's also a fantastic option. Some of the best doctors I know are DOs. And I stuck with my plan, and I stuck with medicine because that was my calling, and I made it happen. Learn from your failures, grow, and be better. So, guys, this is the first little case presentation, how to assess a trauma. So in trauma, anybody comes into the emergency department that's a critical patient. You do a primary survey. A primary survey consists of airway. You're watching the trachea, how they're breathing. Are they making any weird sounds? Are they vomiting? Are they spitting up blood? Are they not protecting their airway? Breathing, so you're listening to lung sounds. Circulation, so you're seeing pulses, you're assessing capillary refill. Do they have, are they hypovolemic, which is hypo means decrease, and volemic is volume, so decrease the volume. Um, you know, Disability, do they have an open fracture of their tibia or femur or whatever, or did they have a stroke? Like, are they not able to move their right arm and right leg? And then environment and exposure. So this is the primary survey, but today we're going to talk about a case that I've already talked about in my last one, but today we're really going to focus on airway and breathing, which are literally, we have to be the masters of the airway. We have to be, because we have difficult airways. Somebody comes in vomiting up blood, or somebody got, cracked in the face and their teeth are all messed up and there's, their face is ripped open, there's blood everywhere. You got to go through the throat, like, surgical airway. There's a lot of difficult airways that we can deal with, and we have to be prepared for them. So here's the case. A 35-year-old male brought in by EMS who reports status post motor vehicle collision, MVC, for all my scribes out there. Around 75 miles per hour. That is fast, guys. Just prior to arrival, patient was a restrained driver and was hit with direct frontal impact. Airbags were deployed. Patient has been intermittently mumbling and only responds to painful stimuli and is unable to follow commands. He's vomited twice in the emergency department and doesn't seem to be protecting his airway. He's gasping. So in real life, this patient would most likely be dead, right? This is an extreme case right here. Or he'd immediately be going to the OR because that is a terrible accident. These are his vital signs: 99 temperature, heart rate 120, probably would be like 150. Blood pressures, hypotensive, 90/60, probably would even be lower. Respiratory rate 24 and agonal, and oxygen is decreasing at 85. So they look at you and they say, all right, what do we do? If you work at a good place, though, everybody's all on top of it. It's teamwork again, guys. It's teamwork. Airway, breathing, circulation, disability, exposure, and adjuncts. Adjuncts are procedures that you can do to assess for these things. And as you move down the ABCs, is what we call them. You move down them, you assess the airway. If they need to be intubated, you intubate them. Then you secure the airway, check the airway is fine. Then you move to breathing. Okay, breathing, okay. Do I need to put a chest tube in? Whatever. Breathing's done. Circulation, do they need a central line? Do they need, volume resuscitation? Do they need plenty of trauma blood? Do they need normal saline? What do they need? Disability, make sure all their fractures are reduced and, immobilized. And then adjuncts, as I said before, EKGs, chest x-rays, all these kind of things. So our patient, we're going to talk a little bit about intubation. So this patient needs an airway because, as you heard before, he's intermittently mumbling. There's this thing called the Glasgow Coma Scale. And there's a little rhyme that, everybody says, GCS less than 8, we have to intubate. This guy is definitely a Glasgow Coma score less than 8, which, if you guys want to look that up, you get extra points. That's actually really interesting. But less than 8, we got to intubate. This guy's like a 3. So definitely an intubation. Team assignments. You are the team leader. You assign, different roles. We have somebody on the airway, somebody on CPR if needed, somebody pushing meds, somebody getting IV access. Many indications to intubate, guys. Respiratory failure. Apnea. Apnea means you're not breathing. GCS, Glasgow Coma Scale, just talked about it. Rapid change in mental status. So somebody who is talking to you and all of a sudden goes obtunded. That's somebody. Airway injury or impending compromise. This is somebody who comes in. Let's say you're allergic to peanuts and you ate a peanut and you start feeling that throat, closing up. It's time to intubate, I think, if the epi and everything else isn't working. If somebody's a high risk of aspiration, let's think about somebody who has epilepsy or somebody who's seizing and they won't stop seizing. Those kind of people are at high risk for aspiration, which aspiration happens when you vomit and the vomit goes into your airway and can cause pneumonia, all sorts of problems, and decreased oxygenation. So you want to protect the airway by putting a tube in it and helping, that patient breathe without aspirating. Trauma to the larynx. This is the larynx, if you guys see right here. It's a little cartilaginous structure right below the tongue that opens up to the trachea, and the esophagus is behind it. Okay. So trauma to the larynx, that's going to be a tough one. That's a tough airway. Let's say somebody gets, punched in the throat or something and it collapses. You might have to do a surgical airway, which is where you take a scalpel and you go down the middle of the cricoid membrane, which is right here, and you go down and over, and then you stick a tube in there instead of going through the mouth. There's a lot of different things you can do. Soap me. Sounds weird, I know, guys, but it's a mnemonic. And it's a mnemonic every ER doc knows or has in their head when they are getting ready to intubate. So there's a lot of things that you need at the bedside when you're preparing to intubate someone. First is suction. As I said before, people are vomiting. They're bleeding from their mouth. They're throwing up blood. They have tons of secretions. Maybe they overdosed on an antihistamine. They're having anticholinergic stuff. Not anticholinergic. Maybe they have organophosphate poisoning and they're, got tons of secretions. You got to clear that out. We have suction to get the airway ready to be looked at and visualized. Because if there's a ton of crap there, you're not going to be able to visualize the airway, right? You have oxygen. Every patient, you should have a nasal cannula on or high flow or a bag valve mask, which is the mask that goes over, and you have somebody squeezing it, right? To oxygenate their lungs and their brain and their heart as much as possible before you take their ability to breathe away, which I will talk about later, a little bit later. So A is airway. You should always have one tube and a backup tube. Every adult male pretty much gets the 7.5 size tube. You should always bring a size down, 7 in that case, especially if there's edema or swelling in the airway. Excuse me. If it's a female, you can get the 7 and go down a half step as well for your backup. And the P, you're going to have a primary objective of getting the airway, obviously, but you also have to have these adjuncts, these kind of backup things, if you will. So we have something called a bougie, which is a very long tubular structure that can help us and assist us actually pass the airway tube, which is called the endotracheal tube, right? And then M, we're going to be looking at medications, right? So medications are huge. Medications we're pushing are going to sedate the patient. So you're going to sedate them first before you paralyze them. And the paralysis is actually kind of scary because you're literally taking their ability to breathe away. And something like that is a huge privilege, I guess, because if you're taking their ability to breathe away and you can't pass this endotracheal tube, you're in trouble because they're not breathing. And if they're not breathing, they're not getting oxygenated. And that's not good. And again, after you pass the tube, let's back up a little bit. Now you're prepped, you have everything, right? Let's look at the patient, right? So you have to assess, are they a large person? Are they a small person? Are they elderly? What's their jaw structure? How big is their neck? Do you think this is going to be a difficult intubation? So you lean the head back, you scissor open the mouth with your right hand, and with the other hand, you have this laryngoscope right here. This is actually a Mac blade. And what you do is you sweep the tongue underneath and you pull up without cracking their teeth. Don't do that because then the future dentists out there are going to have to fix those, and you're going to get sued. So, you go up and that exposes the airway, and this is what you see. Okay. What is all this stuff? I don't know what all this stuff is. Let's talk about it. So right here, we have the true vocal cords. This is where the trachea is, right? So this is the hole that you want to pass the endotracheal tube through. So as I'm doing this and I'm looking down into their larynx, you're looking at this view. This is the view you want, right? And you are not taking your eye off that. If you take your eye off it, you're going to lose the view, right? And then you have to readjust and figure it out. And all this time, the person is not being oxygenated, right? They're paralyzed, they're sedated, they're not oxygenating. So you don't have much time, right? Especially in the ER. If you're in the operating room and you're an anesthesiologist, you have all the time in the world because that is a very controlled environment. And their patients are super oxygenated. But these patients could crash on you in 10 to 15 seconds sometimes, especially if they're in like diabetic ketoacidosis or something metabolic. So without looking away, you take the tube in your right hand and you pass through those cords. What you're looking at here is the true vocal cords, false cords. Oh, let's go back. False cords. The epiglottis, which is this big thing right here. This is very floppy and it actually flops down, especially in the elderly patients. You'll get very floppy epiglottis, and it's very difficult when you get that floppy epiglottis. And you can get somebody with edema around here or swelling and you can't see anything. You can get blood in the airway. Like imagine looking at this with a ton of blood in it, right? That's pretty difficult. The area epiglottic folds are 4, so literally the connection between the epiglottis and the arytenoids, and the piriform sinuses, which is to the right and left, and then the base of the tongue is right here. So what you're doing is this is the face over here, like where the word mirror is, and the tongue is going this way, right? So you are literally like they're laying on their back and their head is tilted back and you are looking directly down into their airway. Here's a little bit more of an advanced thing. And again, this is mirror laryngoscopy. All right, so you pass the tube. Good job, right? You pass the tube. You have a connector that tells you that carbon dioxide is being exchanged for oxygen, which is great. You're having a good volume being put into the lungs, and you have somebody on bag valve mask. So great. Take a listen. You have to confirm the tube is there. So take a listen. Do you hear air in the left upper lobe? If you do, that's great. If you don't, maybe you went into one of the main stems over here with the tube and you got to pull back a little bit. The lungs go, you have the trachea and you have the bronchi. The main bronchi is a bifurcation right here into the left lung and the right lung. So you percuss. Let's just say for our sake with this trauma guy, you percuss and it's really dull. You listen, you're not hearing anything here, right? This is part of the breathing part. And you're suspecting something called a tension pneumothorax. And this is a tension pneumothorax right here. It's an x-ray. This is all air outside of the lung, pushing the lung parenchyma to the other side of the body. Look at this trachea. It's completely to the other side. This is not good. So in this situation, if you suspect a tension pneumothorax, you will see it. It's clear as day. Their trachea is over on this side. They got veins are bulging everywhere. You know if this is happening. So what you do is you take a 14 gauge needle and you decompress. So you stab them in the second intercostal space right here with that to release some air to make this go back to the other side, give you some time before you do the next thing. So what a pneumothorax is, pneumothorax, we have 3 different types. We have the closed, open, and the tension. This is an example of tension with some penetrating trauma, causing air to actually go into the thorax and push the lung parenchyma to the other side. Then you have, again, a closed, which is just spontaneous rupture of a part of the lung causing air in the pleural space. And in the lung, you basically have a sac here and then the lung inside that sac. And if air gets in between the sac and the lung, you can get buildup of air and pressure against the lung, causing this pneumothorax. And again, this does a lot of bad things. It decreases blood return to the heart. It causes decreased oxygenation, obviously, because one of your lungs is not working at all. And this is a really good image right here talking about pleural cavity pressure. So if you guys remember all these physics classes, and all this stuff is very relevant in medicine. So you have to understand physiology before you understand pathophysiology. And what are you going to do? You're going to put a chest tube in. So you need to make sure that you have plenty of anesthesia, plenty of lidocaine placed in the skin. If you don't, it's going to hurt. But hopefully they're already sedated, and that'll be fine. You make an incision at the 5th intercostal space in the anterior to mid-axillary line. Anterior means in the front. Mid-axillary is axilla, is the armpit basically, and the middle of that. And then just anterior to it in the 5th intercostal space. This is 1, 2, 3, 4, 1, 2, 3, 4, 5, right there. And then what you do is you place the chest tube, right? So you proximal end of the thoracostomy tube clamped and advance through the incision into the pleural space. And then you have to suture it down. And what that does is that releases the air or fluid or blood or whatever is in that thorax out of the body and helps your lung re-expand. So good job, guys. You saved them. So that's a little bit about airway and breathing. How much time I got? 42. Think I got time for another quick case, guys? Maybe? All right. I don't know where the chat is. Oh, here it is. Okay. Got another case. Let's see. And then we'll talk about the end of this. So this next one is we have a patient. Patient is a 74-year-old male brought in with a history of emphysema. Emphysema is a disease that a majority of the time is caused by smoking. There's obviously a lot of different other things that can cause emphysema, which is a type of COPD, chronic obstructive pulmonary disease or disorder. So this guy, he's already got sick lungs at baseline, right? He's 74. He's an old guy. He's got emphysema. He's probably been smoking cigarettes or vaping for years, for all you vapors out there. 74-year-old brought into ED, the emergency department, via EMS, emergency medical services, for SOB. Not son of a bitch, but shortness of breath. They've actually changed that now to DIB, dyspnea, or difficulty in breathing is now the new thing because people are getting upset that they see on their chart SOB, which I think is kind of funny. So triage vitals, heart rate 118 per minute, blood pressure is a little bit elevated there, 170 systolic, normal is 120. In the elderly, expected to be 140, 150, and that's normal. Respiratory rate normally is 12 to 16. This is 28. So tachypnea means they're breathing very quickly. Temperature, 100.5 is a fever. So guess what? We got a fever. And the oxygen saturation is not looking good at all, 86%. Normal is over 90. This guy's emphysema, probably a little bit less than 90 is his norm. So it's a little bit decreased in oxygen. And that's because COPD, people at baseline have a decreased oxygen because their lungs are already pretty crappy to begin with. You get an EKG and it's just got low voltage, which means some of these complexes are a little bit low, and you see a fast heart rate. So how you do this is each little box is 0.04 seconds. So every big box is 0.2 seconds. And what you do to measure how fast the heart rate is you go from one QRS, which is this bigger one here, to another QRS. And you do, each box is, you start at 300. So 300, 150. So it's a little bit less than 150. As I said before, it was like 120 something. I forget. Sorry, 118. So this is not the right EKG, but it's just there for teaching. And some other stuff, but no heart attack. You don't see anything like that, which is good. So you're like, all right, well, what's causing this difficulty in breathing besides the COPD? pH 7.32. What is normal pH, guys? 7.35? No, 7.4? Yeah, that's physiologic pH, around 7.4. Good job, guys. So a little bit low, but it's okay. Again, this guy is, he's kind of sick at baseline. His CO2, his carbon dioxide is 70. He is retaining a lot of CO2, and we know he has emphysema, but it shouldn't be that high, right? CO2 should be around the 45 mark, right? Lactate, elevated. Lactic acid, what happens with lactic acid? It goes up when you don't have enough oxygen around. This is telling us there's either an infective process or something that's causing decreased oxygenation to tissues. And some of the other labs, that's all fine. You don't need to worry about that, guys. These are all just numbers. And this is a normal x-ray, right? Just to give you guys a little indication between normal and abnormal. Okay. Does anybody see the difference between these two x-rays? Anybody see a difference? The liver. So what you're seeing right now is you're seeing, let's just talk about it real quick. So this is actually the diaphragm, right? The liver is underneath this diaphragm. That is correct. And over here, you see the stomach, right? And that's fine. Let's not pay attention down here, all right? How about this? This is all normal lung tissue. This is the contour of the heart, right? On this side, this is the aortic knob right here. So the aorta shoots off the top of the heart and goes down the rest of the body, right? Trachea, as we said before, right main bronchus, left main bronchus. Good. Normal lung. There's some vasculature markings. This is the hilum. This is a hilum. This is fine, right? Let's go to the next one. We see trachea, bronchi, good. The upper zones look pretty good. Heart's a little bit big. That's fine. I don't like this. This right here looks like something called an infiltrate. So the lungs shrunken they're not shrunken. It's probably just the body habitus of the person, right? Maybe this is a shorter person than this person. This person looks like a tall, young person because they look like very healthy lungs, as well as very long lungs. It's not a COPD presentation here. This is probably an elderly short grandma, right? So she's got smaller lungs. And again, inspiration changes how big your lungs are and how pushed down the diaphragm is compared to from one to the other. So this is not the greatest image, but the whole point of this image is to show you guys this right here. Look at this. There's nothing. This is good. And then look at this. Right here, we have an infiltrate, which is either atelectasis or pneumonia. And in this patient, we just diagnosed pneumonia, causing this patient to go into a COPD exacerbation. An exacerbation means a worsening of their already chronic state. So this person is already sick at baseline, and this pneumonia sent them into a not so great state. So when you're thinking about COPD, you treat with bronchodilators. And as I said before, this is the main bronchi right here. And then you have tiny little bronchi all throughout the lung that open up airways, right? What you want to do is you want to try to maximize the circumference of each of these bronchi, right? This is how you get air, right? So what is it? R to the fourth power. There's Poiseuille's law for all you guys out there, all you physics nerds. Poiseuille's law tells us that flow is going to increase with a larger radius and shorter pipes, right? So when you're sending the air through, You want to dilate as much as possible. And something we do for asthmatics as well as people with COPD, we bronchodilate them. We give them something called albuterol. Albuterol, for all you guys who are asthmatics out there, is something that helps bronchodilate. Anticholinergics. This is something called tiotropium. This is something that decreases bronchoconstriction. As I said before, we need to bronchodilate. Constriction means to tighten. And then it inhibits mucus production, which also can cause worsening of this decreased oxygenation. Glucocorticoids are going to suppress an inflammatory response. And then magnesium is actually for more severe kind of stuff, and actually can be given to severe asthmatics. Helps a lot, actually. And then antibiotics. We got to admit this guy for community-acquired pneumonia. We got to start some antibiotics. So we're going to start giving them some Rocephin, which is the drug is a ceftriaxone, which is a third-generation cephalosporin. If you guys want to look it up, there's so much on antibiotics that a fantastic resource. If you guys, when you guys get to medical school, is Sketchy Farm and Sketchy Micro. Fantastic learning program. Awesome stuff. And that helped me big time to remember all the antibiotics and all the different microorganisms and what they're susceptible to and blah, blah, blah. So again, this patient had pneumonia, COPD exacerbation, irreversible alveolar destruction. So a way that I describe COPD to people is think about a normal lung as an elastic balloon that you can blow up and it goes back and it can go back out, right? It has that elasticity. And think about COPD as somebody trying to blow into a plastic bag, right? It's really easy to blow up, but there's no bounce back, right? There's no bounce back. So once that air is in there, it stays open and slowly goes down. So you can think about COPD as a plastic grocery bag filling up with, air. So that was actually the best way that I could explain it to you guys. Obviously, there's so much more to the pathophysiology of it, but because, you guys aren't in med school yet, I don't know how many of you have actually taken anatomy and physiology and all these other things. So I don't want to confuse any of you out there. I'm trying to keep it as watered down as possible. Okay. So now we're getting to the end of my presentation, and just going to talk a little bit about emergency medicine. When you make the decision to do EM, you have to really kind of see yourself in every other specialty. You have to, first of all, go through all your clinical rotations and see what you like, what you don't like. But you also need to keep an open mind. Don't just pigeonhole yourself to emergency medicine. That was one of the best pieces of advice I was ever given. So when you do figure out it is for you, ask yourself these questions. When you walk through the doors of your emergency department, do you get an overwhelming feeling that you belong there? Do you get along with the people? Does it just feel right to you? Does the thought of a trauma or code where you can save a life give you a surge of adrenaline and excitement? It sure does for me. When you see a stranger who is injured, do you run to them or do you just say, nah, whatever? Like the radiologist, correlate clinically, that's fine. Do you enjoy the diagnostic inquiry of undifferentiated illness? Again, like the pipe, Sherlock Holmes, right? Do you enjoy investigative work? I find that really cool that you get to figure out some really cool illnesses with just clues and asking questions and diagnostic workup. Do you enjoy a wide range of clinical challenges requiring a variety of skills each shift? So I think that emergency medicine doctors in the real world are the most well-equipped to deal with a sick patient. Like if you're ever on a plane, you really want an emergency medicine doctor on there. They are the MacGyvers of medicine because they can make do with very little. Do you enjoy a fast-paced work environment? As I said, it's patient after patient after patient, sick person, not sick person, crazy person, psychotic person, someone's giving birth in this room. There's all sorts of craziness. Advice for you guys: if you are willing to invest everything you have to get to where you want to be, you will get there. I promise you that. Remember, you are your own investment. So I think this is perfect for all you pre-meds out there and all you kids that are really interested in medicine in general. Doesn't need to be emergency medicine. Just anybody who that you feel like this is your calling. Don't give up on it. It took me a while, but at the same time, I'm here, and it's pretty amazing that I get to go into work every day and see people sometimes at their worst, and try to help them through those times. And again, you can help people in a lot of different fields, but medicine is very special. And it is a huge privilege and honor to be able to see people on their worst days and help them get through it. So if it is something you truly want, I 100% believe you can get there. It's just a matter of time and how much effort and how much you're willing to invest in yourself, and know how hard you really do need to work to get there. Someone said recently, I saw like, oh, you're a doctor and you're 30, didn't it? Like, isn't that a long time or whatever? And the person's response was, well, I'd rather be a doctor at 30 than not. And I thought that was pretty cool. But at the same time, yeah, it's many years, a lot of frustration, a lot of sacrifice, a lot of money, a lot of time, a lot of time away from loved ones. Relationships suffer, all sorts of things happen. But if it is truly your calling and it's what you want to do, then remember, you are your own investment. Okay, guys. So thank you for attending. It was a lot of fun. I'm glad I got through both cases, actually, and just in time, too. You guys can follow me on Instagram if you want, at Doc Riles. I've been getting a barrage of messages saying to do TikTok. I still refuse to do TikTok. Maybe I will do some educational ones. I've had a couple people reach out and asked if they want to do a collaboration, but we'll see. Podcast, RESLIFE podcast, guys. This is chock full of information. The whole point of me doing this podcast with Dr. Schuper, was so that I can share my advice on my road to medicine, and he can share his advice on his road to medicine. The dude's a neurosurgical resident. He's second year. He's going into his third year. I'm emergency medicine. They're pretty competitive specialties. Obviously, that's a lot. That's on its own category. But at the same time, we went through all of it. We both did gap years. We lived through the struggles of getting through all of this. And there's a lot of invaluable advice on there. We're starting to interview residents in other specialties too, so they can talk about their specialties. I do an emergency medicine one. Dr. Schubert does neurosurgery. We have another resident, Dr. Ravin Patel, who does family medicine. We're going to get an anesthesiologist soon. We're getting a lot of different people. So if you guys, have access to Spotify or whatever, just subscribe to the podcast. Me and him are going to start cranking out some more pretty soon. So thank you guys for attending. Let's see if we have any burning questions before the time runs out. Good books to recommend. So I think one of my favorite books of all time is actually Make Your Bed by William McCraven, who is a former Navy SEAL. I actually talk about it in one of my day of the life. So one of the things that I do now every morning is I make my bed, because no matter how crappy your day is, at the end of the day, when you come home and you see that perfectly made bed, you did something right that day. No matter how many times you screw up, how many failures you have, you made your bed perfectly. That's a very motivational book. Fantastic. In terms of pre-meds, When Breath Becomes Air, oh my God, guys, you got to read that book. It's fantastic. Let's see, what else? I have so many books everywhere. Obviously, Tintinelli's Emergency Medicine. Also, if you guys are a med student, make sure you become an EMRA member if you're interested in emergency medicine. They have the best resources for you guys. Okay. What was your least favorite part about going to med school in the Caribbean? So honestly, the med school part, because med school is tough and it sucks wherever you go, right? It's the same information whether you go to Harvard or you go to St. George's. It's all the same information. Every medical student has to be competent in these things. We all take the same board exams. I actually did killer on my board exams, very competitive compared to US med students. And I'm very proud of that because I worked my butt off to do that. So, yes, the worst part is studying. I know it's terrible, but at the same time, you're learning, and the motivation to keep studying is that what you're learning can possibly help you save somebody's life someday. And that's what I would tell myself, at least. So, that was probably my least favorite part. Man, Grenada is a fantastic place. A lot of students would not say so because they did not explore the island. They did not embrace life in general. They would just sit in the library and say they studied for 16 hours, but they were actually on social media and YouTube and Netflix for like 8 of those. So what I would do is I would study, I'd get my work done. I'm very goal oriented. I get my work done, then I can go do whatever I want. So I had a band I would play at the local brewery down there. So much fun. Yeah, it's a rainforest island, so you'd actually be able to like drive all over the place and explore some of the waterfall parks and stuff. It was great. The beaches were fantastic. So I thought it was a pretty cool place to be, for medical school. Obviously, I'm not saying it's a walk in the park. I had to work 10 times harder than a US medical student because of the stigma against Caribbean grads for residency. And I had to do that much better. And I had to do that many more things to match into a competitive specialty, such as emergency medicine. So, how do you stay organized in a very hectic emergency room? Honestly, everybody has their own way of doing this, but I personally, I take a sheet of paper, I fold it in half, I make lines, and I write down a first name, what room they're in. I write down like little tidbits of information. I'll put like labs, imaging, whatever, and then I'll check off what's done. And then I'll keep updating the patient constantly. If a code comes in, that takes priority over everything, right? EMS comes in, there's a super sick patient. You got to go see them right now. Drop everything that you're doing, go to that. You'll get back to your notes and your dictations later, which is another really annoying part of emergency medicine and medicine in general. It's really hard to stay organized. That's for sure. So if you're someone who needs everything prim and perfect all the time, that is not the emergency room. That is for sure. I think all my ADHD people out there would probably really enjoy emergency medicine because you're going from one person to another. I do not have ADHD, but a couple of my co-residents actually do. So it makes sense. As an EM resident, how is dealing with your first chaotic case, especially considering residents are still learning how to do procedures? Honestly, I talked to my program director about this the other day. So, because we started in COVID times, COVID was at an all-time high in the Tampa Bay area when I started my residency. So that was crazy, walking into that absolute just disaster. Patients coding left and right, people coming in via EMS with the automatic CPR machine. It's called the Lucas. That was my first week. And I remember we didn't get to meet any of the other residents because everybody was quarantined and you're not allowed to go anywhere but inside the hospital and home. Never got to hang out with my co-residents or anything the first couple months. And so I didn't know anybody. I didn't know faculty, and I would just show up to work. And one of the core faculty was like, all right, Chris, EMS coming in, you're getting the airway. And I was like, whoa, what? We haven't done any simulation. We haven't gone over airway stuff. And here I am at the head of the bed. I'm just like a nervous wreck. I have no idea what's going on. I haven't intubated someone since like being on anesthesia, third year in the OR. And I'm ready to go. And the doc sees that I'm hesitant. And he's like, what are you doing? Like, no, give me this stuff. I'll do it. He did it. And I remember him saying, you need to practice your stuff. You need to know what you're doing before you do this. And I was like, Doctor so-and-so, like, I have no idea what I'm doing. I just started this week. He's like, oh, I didn't know you were an intern. So that was terrifying. But my first shift back in a couple months, the other day, code came in. I was at the head of the bed, airway like that. I've done like a little bit less than 50 intubations now as an intern in anesthesia rotation and in our ED. We have a very sick population that comes in. And I'm extremely confident with my intubations now. Not to say that I'm not cocky about it. You never want to get cocky about anything in medicine, because that's when shit hits the fan. And when you start being overconfident about stuff, you always need to respect the sick patient. You need to respect the airway big time, because you could lose an airway like that. But I just reflected back and I was like, wow, what a difference a year makes. It's crazy how much more confident I feel as a physician. So that was very frustrating. You mentioned something about relationships suffering. Is this particularly in competitive fields such as EM or in all fields? Medicine in general. A lot of people deal with relationship problems, especially if their significant other is not in the medical field. They could try to empathize with you all day long, but they will never understand what it's like. I have friends say, oh yeah, I'm in nursing school or I'm in PA school, so I know what you went through from med school. And I'm just like, not to knock any of those people, but when they were like, I had a nurse anesthetist say, oh, I know what you're going through. Like, she's like a first year nurse anesthetist student. And I was just like, what are you talking about? Like, but in my head, I'm like, yeah, or out loud, I'm like, yeah, but in my head, I'm like, you have no idea what you're talking about. It is something that you cannot explain. You just need to experience it. And then you'll know what it's like to be in medicine. It's very, very challenging to get through medical school. A lot of stress, a lot of fights with significant others, um, a lot of neglecting your family, your friends. Family is everything to me. And just the fact that I was in Grenada was really tough for me. I'm from New Jersey originally, so very far from my family. Luckily, I could fly home, so you apply to the Caribbean separately. You have to reach out to individual schools, and they look at your transcript, which is based on AMCAS. You can send them your AMCAS ID, I believe, and they can look up all your information. And you could even apply and get a preliminary acceptance before you apply to US MDs and DOs, and they can give you that acceptance and hold it just in case you don't get into a US MD or DO school. You can still go to the Caribbean. I mean, even their people, they say if you get into a US MD or DO, just go there. All right. Because it's 10 times harder to get into a residency program or competitive residency from a Caribbean school. And that's the truth, because we have to work that much harder. We have to do all these outside things, get all these certifications, do, much better than average on the STEP exams, which are the board exams. You have to be extremely competent. I know for sure. I mean, I belong in medicine, and it's just it's a tough thing to deal with. So anyway, that's about all the time we have, guys. So thank you for joining me, and again, web shadowers, thank you guys for having me. It's always a great time being here, and I hope this one was a little bit less rushed than the last one. So
Thank you so much, Dr. Reilly, for another wonderful presentation for our web shadowers. You provided so much information and a lot of inspiration to us as well. So thank you for coming on again. And everyone, please check out his socials to learn more from him. His Instagram is at Doc Riles, and his podcast is RESLIFE. The link to the Google form is now being posted in the chat, and you will also be able to find it in the description of this video as well. Again, thank you all for attending, and thank you so much, Dr. Reilly.
of course, it was a great time.